مساء الخير وصباح الخير جميعا. Thank you very much for CIFA project and the scientific committee for the invitation to chair this session. I'm very delighted to be among such respected speakers today, and it's a pleasure to introduce them and moderate this session. I would like to start the session by introducing the first speaker, Dr. Isra Al-Tawil. Dr. Isra is a consultant clinical pharmacist specialized in critical care and parenteral nutrition, and she is the coordinator for parenteral nutrition at King Saud University Medical City. She received her bachelor degree from King Saud University as well as the master in clinical pharmacy in 2012. She earned her board specialized residency in parenteral nutrition in 2014. Furthermore, she has gained 3 board certifications from American College of Clinical Pharmacy in pharmacotherapy, nutrition, and nutrition support and critical care. Dr. Al-Tawil has a clinical work she is currently the deputy chair for pharmacy and therapeutics committee and the program director for specialized BGY2 in parenteral nutrition. She has interest in research, nutrition support, critical care, and pediatric surgery. So without further ado, I would like to give it to Dr. Al-Tawil to talk about the PNT role during the pandemic. تفضلي دكتور.
Assalamu alaikum. Hi, everybody. Thanks, Dr. Hani, for the introduction. And thanks for Dr. Muhammad Asiri and the Scientific Committee for giving me the chance to be part of such a great annual conference. Actually, my talk today will be about the Pharmacy and Therapeutic Committee role during COVID-19 pandemic, which is such a stressful condition that we are facing. I have no financial relationship to disclose. And the objectives of my talk, by the end of my presentation, I'm going to discuss the role of the PNT committee during COVID-19 pandemic and what are the challenges of the pharmacy and therapeutic committees and the ethical aspects of using the off-label and compassionate use of drugs. So we'll start by giving introduction about the current situation and what was the PNT committee preparation plan in our hospital and different institutions. Then I'm going to have some slides about the role of the PNT committee in using of the COVID-19 medications, rapid establishment of therapeutic protocol. Then after that, we'll end by discussing the challenges and the ethical aspects of off-label use of drugs and the compassionate use of medication. Then we'll summarize the whole plan. As we all know, in December 2019, a pneumonia of unknown cause started in Wuhan, China, and it was reported to the World Health Organization country office. This coronavirus, COVID-19, quickly turned into global concern and pandemic with its rapid spread. Unfortunately, on March 2020, the first case announced by the Saudi Ministry of Health. Facing this COVID-19 pandemic with the problem actually of the high rate of the virus transmission, mortality and uncertainties about the novel of about this novel infectious disease have resulted in the surge of new studies and data. And PNT committee as integral part of the hospital steering committee has a role as and charged with providing the rationale and advice with the use of medication throughout the institution. And as we know, this global pandemic put a pressure on the clinician and the different committees at hospital and higher administration to make and to act swiftly to make all these medication available to the patients. So what was our preparation plan? First of all, we decided that the P&T committee need to meet more frequently. Our meeting usually monthly basis. Then after that, we decided to make it more frequently to assess the situation and plan. And the institution need also to explore the potential unproven therapy carefully while weighing the priorities and the burden on resources. So the aim actually to study the repurposed medications, to study the stocking of these medications and establishing a therapeutic protocols. This was done by reviewing all of the available evidence and provide advice to the committee continuously. So we started by, first of all, the drug selection. As we know, most of the studies in the beginning were poor to very poor quality, with limited number of patients recruited to clearly extrapolate the effectiveness. And all of this emerging evidence on a drug selection was evaluated and used to formulate like a recommendation to the hospital planning on increasing the stock and availability, not only on the antiviral or repurposed medication, but also for the suppurative drugs that used for the patient admitted to the hospital. The criteria on selecting which medication to be used, only we select that treatment that were used in clinical studies and show effectiveness, not reported harm because patient safety is first, and were easily accessible by the institution. After drug selection, we take into our consideration the drug logistic consideration. As I said before, that beside the antiviral directed treatment, identifying the suppurative treatment that's needed for infected patient, not only the infected with COVID-19, but also the patient admitted to the ICU or the ward, it's maybe more important during this pandemic, and frequent assessment of the stock, because we expected that the stock will be increased. As we know, shortage and lack of these suppurative medicine, it's also harmful and may increase the mortality. So the effort to identify the early signs of any supply chain shortage was taken into consideration for these suppurative drugs. I mean by suppurative medications like fluid, albumin, electrolytes, corticosteroids, antibiotics for the secondary infection, stress ulcer prophylaxis or proton pump inhibitors, etc. After that, estimating the number of patients, forecasting and estimating the number of patients was done with a brief cost analysis of the potential treatment was taken, with priority was given to the most effective medication. Of course, as the P&T committee act as an advisory committee, it was important at this time to eliminate, to debunk any misinformation, any misleading information. Quickly search the evidence and select the most appropriate regimen or therapy despite the limited evidence, and make appropriate decisions, of course, with the help of the Ministry of Health protocols that was updated frequently. So our role in choosing or the use of medication, first of all, we have to make it an expedite way of review, appropriate decision on allocation of repurposed drug, and also develop restriction and protocols to stop any misuse of medication. The well-known example is restricting hydroxychloroquine. In our hospital, we restricted to rheumatology and ID, because you cannot imagine if a patient diagnosed with SLE and who's dependent on hydroxychloroquine, then this medication has run out of stock. So it will be harmful for him, same as the harm of COVID-19. In addition, we, a second example, we did a guidance of using tocilizumab was done by the Pharmacy Practice Council. How we work to establish these protocols. It wasn't a single work of the P&T committee alone. We discussed how the evidence was evaluated in interprofessional setting, focusing not only on the quality but also the application of these protocols. The goal was actually to limit any variation in practice. We try as much as we can to unify our practice and to create like a shared mental model for delivering of these guidance. P&T committee liaise with different departments like the Emergency Preparedness Committee, Infection Control Committee, and the Hospital Higher Administration. We try as much as we can to build this protocol into electronic medical record system, so it will be available for the whole healthcare provider who's dealing with these medications. Most of the medication that used as repurposed antiviral medication were as off-label use, because as we know, there is no specific effective treatment. And the choice of off-label medication is more complicated when there is less cut and clear evidence. According to the World Health Organization, if we can use the off-label use drugs if the condition justify this use. So it's in case of serious and life-threatening condition, and when there is the evidence of potential benefit outweigh the risk, and if there is no standard therapy, and of course informed consent is needed. While if we use any unproven investigational drug that's not approved yet for a patient with serious life-threatening disease outside the clinical trials, in this case, we call it the expanded access or compassionate use of medication. And I will go in the coming slides through all these pathways to explain more what do we mean by each one. The World Health Organization actually considered the off-label use of medication under the regulatory or the national regulatory specific to each country. So it's a country specific. For example, the way how they are dealing with that in Europe, it's different from Australia, from US. European Union legislation, they regulate only the marketing process and not directly regulate the application. While in Australia, they justify the use in different 4 levels. For example, if the disease or there is special clinical circumstances in case of serious or life-threatening or rare diseases, if there is limited quality or low to moderate quality evidence when the drug is used as investigational. While in US regulation, the investigational use of off-label medication, they think that it will help, which is a smart way actually, will help in the development of their safety and efficacy data, which is needed if in the context with it's inapplicable to make a clinical trial. And they did they released a new guideline entitled FDA Guidance on Conduct of Clinical Trials of Medical Products During Pandemic. Actually, this guidance, the most prominent necessity to be saved is the patient safety, and all other requirements for the application is mandatory as well. Unfortunately, during actually COVID-19, we faced a third type of off-label medication. It's not off-label, it's not compassionate use. We faced what's called a pseudo research. Pseudo research is defined by we are using this off-label medication in clinical practice without obtaining the patient consent. And furthermore, they are finally publishing the result as a research article of the drug safety and efficacy. It could be considered unethical for many reasons. There is no proposal. Validity of the method may be under question, and the results could be of little value. But if we think more about it, it may give us a guide or give us like a clue about the drug efficacy and safety in which we are unable to get the informed consent and conduct a clinical trial. This is the different access or different pathways to get a drug. We have the compassionate use, off-label use, and the clinical trial. The compassionate use or the expanded use, we give access to the patient in absence of any satisfactory alternative therapy in case of the serious or life-threatening condition like the COVID-19. Informed consent may be or may not be required. This depends on the country specific regulation. And the well-known example is the use of convalescent plasma. For the off-label use of medication that we use a well-known approved medication, but it's not used for treatment of this X indication. So we use approved drug for other indication. It can be used for any disease, not only the COVID-19. We don't require informed consent, but we regulate the use, of course, of off-label use in our hospital by restriction, protocols, and filling Form B. I think this Form B, it's applicable in most of the institution here in Saudi Arabia for any unapproved drug. Example is using hydroxychloroquine, Kaletra, tocilizumab, dexamethasone. While a clinical trial is a clinical trial, it's a demonstration of the efficacy and safety of a drug for prevention, treatment, prophylaxis. It can be used for any disease. We require informed consent to be taken from the patient. Actually, most of the drugs that use off-label or compassionate use, they apply it in the clinical trial, like the remdesivir, the convalescent plasma, which is a compassionately used, hydroxychloroquine, and the well-known Solidarity trial. Solidarity trial, it's a World Health Organization expert group mortality trial. We are lucky at King Saud University Medical City. Our department were a part of it. They use 4 repurposed antiviral drug, remdesivir, hydroxychloroquine, lopinavir, and interferon beta 1A. In patient hospitalized and diagnosed with COVID-19. They randomly assigned the patient into 5 arms, the 4 repurposed antiviral drugs, and the 5th was actually an open control, which is a local standard of care. This is the trial if anybody interested to go and read it. So what are the challenges of using this compassionate use of drug? As per the US FDA, there is some condition that justify the use of this expanded use of a drug. If the patient suffering from serious life-threatening condition and there is no available alternative treatment. Also in case if the enrollment of patient in clinical trial is not possible, and this was actually the situation. And if the benefit outweigh the risk of treatment, and if using this investigational drug will not interfere with the clinical trial that are conducted for the marketing approval of the drug.
3 minutes, Doctora.
Okay, if you think more about it, the compassionate use, it may bridge the gap between the development phase and the final approval. We'll get some hint about the efficacy and safety data that were collected during using this medication. But the main concern actually is the cost of the drug. Some of these antivirals and some of the repurposed medication were biologic with the high budget constraint. Ethical aspects, actually, they see usually the compassionate use as a therapeutic process that's not planned appropriately, no informed consent, validity, and of the method. In view of this, a clear and robust guidance and regulatory policy should be taken on this compassionate use, and this is actually was part of the Pharmacy and Therapeutic Committee rule in the regulating the use. So what were our preparation plan? First of all, to study the evidence of these drug access through different pathways, the off-label use, compassionate use, and any drug under clinical trial, and conducting actually clinical trials to secure access to medication through this pathway. estimate the needed supply of these drug with the help of the planning of the hospital and the budget impact analysis. The most important plan was to ensure the safety on the patient with continuous follow-up of the patients who got the medication through medication safety subcommittee, and estimating the number of patients who would require these antiviral repurposed drugs or even these suppurative drugs. Initiate and approve guidance and protocol to control the use of off-label investigational medications, and finally, work closely with other departments. So what was your institution plan? Thank you so much.
Thank you so much, Dr. Isra. That was very enlightening, and I mean, lots of things to learn from. Just want to ask a question, but if the Q&A session is not going to be active, so I would like to ask you a question. How did you cope with the challenges in communication with the members of the P&T committee during the pandemic? Lots of changes in the practice, and you need to communicate with all in order to get the resolution for that. So if you can tell us about your experience in that.
Actually, it was maybe one of the very difficult situations we faced it because we turned our meetings to be frequently through Zoom. It was virtual meetings, and you know, problem sometimes with these virtual meetings, you may not be able to get the full feedback. Actually, voting was electronic through electronic system. And communication with the continuous letters that we are sending to, even for the members of different subcommittees or the P&T committee and the other department.
Great. Thank you very much, Doctora, and highly appreciate your participation and the experience shared. Shukran jazeelan.
Shukran jazeelan.
Okay, so we move to our next lecture. Our next speaker is Dr. Abdul Mohsen Marghalani. Dr. Marghalani is the Director of Pharmaceutical Care Services at King Faisal Specialist Hospital in Jeddah. Dr. Abdul Mohsen gained his bachelor degree in pharmacy in 2010 and Masters of Clinical Pharmacy in the bachelor degree, he got it from Australia, and the master's degree, he got it from UK. He worked in Australia in a retail pharmacy before coming back to Saudi Arabia. And he joined firstly in IMC Hospital, International Medical Center in Jeddah, then moved to King Abdullah Medical City in 2012. He was head of outpatient pharmacy up to 2016. In that time or that year, he joined Security Forces Hospital in Mecca as the director of pharmacy in there. Then in 2018, he joined King Faisal Specialist Hospital in Jeddah, where he assumed the role of director of the pharmacy department in 2020. In that same year, he also gained his MBA degree. Dr. Marghalani will be talking about the managing the pharmacy workforce during the pandemic and the experience of the department and the hospital during that time. Tafadhal, Doctor.
Thank you so much, Dr. Hani, and thank you, SIFA and SPS for inviting me today. And would like to thank also the scientific committee for giving me the opportunity to go over the journey we had here at King Faisal Pharmacy, Jeddah. Do you see my full screen?
Yes.
Good. All right. So good afternoon, everyone. Today we'll be talking about hospital pharmacy services as being an integral part of the healthcare delivery during COVID-19 pandemic. So the overview and the objective is how we managed the pharmacy workforce during the pandemic. Of course, whenever we want to manage something during, we need to look at the pre and during and post. This is what we are going to show in our slides, inshallah. So managing the workforce formula. Do we have a magic formula? No, we don't. There is no magic formula. We need to look at the demand and the supply. Of course, there will be a huge demand for patients, so you need to supply that on the other side. Services. So you have your normal services and services that you used to do it that you need to cover. However, with the pandemic, you will have newer services that you need to cover as well. Also, you're going to reprioritize your services. Maybe you will find services that no longer needed temporarily as well. And we all familiar, and I wanted to start my slides with this, we're all familiar with the global stock market and how they crushed around March, April. And at this time, the pharmacy have surged with their services because we had a lot of demands and our demands have increased. New services have been introduced. So I kind of put exactly the opposite of the curve. And now we are meeting back and trying to get together and going into the market. So pre-COVID-19, before it got us hit here in the kingdom, we looked at ideas and we were trying to predict what's going to happen. We have kind of like enthusiastic about the whole thing. Yes, we had some concerns. We developed some risk mitigation plans, and there were almost over 20. So in terms of the supplies, and I think Dr. Isra covered few of that. However, from a logistics part, we said, what if we dispense our medications for 2 months rather than 3 months? This is because of the issues of the flights and the cargo. Then we said the COVID-19 medications and medications that potentially going to be used in the ICU needed to be secured, needed to be verified and monitored on a daily basis. Service points, we established the drive-through pharmacy. We established a pharmacy call center. We had voice messages for patients who are willing to take their refill, so they can send us a voice message and we will get into that request. We had 3 extensions directed to staff where if patients had, if they're going to have any medication issues, they can call any of these 3 extensions. Drug information was there. Pharmacy administration, also we put a dedicated extension for that because there is no paper anymore. Patients will no longer be able to take a piece of paper and file a complaint or a suggestion. So we said we can have it there. Mail order, we included patients who are living in Jeddah because before we were mailing medications only outside of Jeddah. So we included them. And we also established a home delivery by the pharmacy staff for Jeddah region, especially for narcotics and controlled biologics and fridge items. As you all know, with the help and support of the MOH and with the leadership of Dr. Mohammed Shinnawi, that narcotic and controlled were kind of being supported also during the lockdown with the courier services with a certain criteria. But biologics, I believe we still have a concern on this one. Also, as part of the pre-COVID, we had to make sure that all the precautionary measures were met, like the infection control instructions, inpatient pharmacy, and the exchange activities between the COVID-19 wards and the pharmacy. You talk about code boxes, we talk about the returns, we talk about refilling using PEXs or cassettes. So all of these were carefully looked at before we got hit here in the whole kingdom. In terms of the outpatient pharmacies, we said, what if we expand our waiting areas? So we looked at the prayer areas that are used for praying, obviously, but we're closed as a mandate. So we use that to expand our outpatient pharmacy. However, having said all of this, we did not put a plan for an outbreak. We suspected that few of the staff might get infected. So 1, 2, 3, that's fine. We can manage with that, but we did not put a plan for an outbreak. So things were going good. As you see, here's the sign for the drive-through pharmacy. And you see, this is the drive-through pharmacy. And this is where we located our drive-through pharmacy. This is King Faisal Hospital, and this is Saud Al Faisal, Prince Saud Al Faisal Street. And this is the car park that belongs to the hospital. So we put it all the way inside using a porter cabin. So we made like a zigzag inside here. So we will not block any of the public roads outside the premises of the hospital. So this is the drive-through pharmacy. So things were going good. And this is our effort to transport medications using our pharmacy staff, using the mail order, using fridge containers to transport medications, and also our pharmacy call center, as you see here, that they were taking the calls and everything. And if you notice, this is an old picture that was before COVID-19 hit Saudi Arabia. There was no kind of like mandates to cover to have the mask on mandate. So what happened? So when we got hit here in Saudi Arabia and cases started to accumulate in the pharmacy, we had an outbreak. The exposure list was very high. So not only the staff who got infected, no, we had also those who were exposed to those other staff. The outpatient pharmacy, the staff went less than 10%. We had to close all of our outpatient pharmacies. We had no way to go. Again, all precautionary measures were followed. However, as you all know, that the restrictions from MOH all the way to the hospitals were gradual. So at that time, we did not have a mask on. Then we had the mask on. So we kind of got hit in that gray area really hard. So with anything in life that, you get hit, but then you have to have a recovery plan. So with the recovery plan, of course, you would consult your pharmacy seniors, you would consult the staff, everyone in the pharmacy. However, there is also one thing that you need to think outside the box. So what I did, I consulted a few of the directors here in the Western region. So I remember also the call I made with Dr. Hani Al-Hamdan, who is our moderator today. And he asked me, what if you outsource? What if you outsource the whole outpatient pharmacy now until you get your staff back? And that was a brilliant idea. So what I did, I took the initiative. I went to private hospitals. I went to private pharmacies. I explained to them. It was a little bit difficult, to get it done in a very fast kind of way. So we went to the MOH, Shu'un Al-Sahiyya fi Jeddah. I'm really grateful for their quick response to have an agreement overnight. All of our patients can be served in any of the MOH hospitals here in Jeddah. So what we did, we were filtering patients here in the hospital based on their specialties, especially those who are on a transplant medication or oncology medications. They had to stay. The rest were transferred to other hospitals. Discharge medications were done by the inpatient pharmacy because there is no one in the outpatient. And this is a practice here in King Faisal that all discharge are done by the outpatient. we had to create 12 remote access for staff who are on the exposure list. Yani they are exposed, they might get sick or not. However, they were so supportive, they were so into the whole situation. So they were verifying orders and taking care of all the orders from home. However, we needed manpower to fulfill those orders on the ground, and that was the challenge. So we have the infected staff. Yes, we had to be busy with the operations and helping our patients. However, we should not forget about our staff. We had infected staff. So what we did, we were following up with them on a daily basis. We had to put someone dedicated for COVID-19. You will get information from MOH, from the hospital, from infection control, and come back to us and inform us. We didn't have the time to do everything because we were so into the operations. We had very, very few staff, a lot of patients outside, a lot of patients are waiting for their medications to be taken. However, with all of this, we had to engineer the whole thing, repurpose, distribute the work across the whole staff. So we had to put someone to get anything related to COVID-19 and help us with that, to better take decisions. With the staff and family, as you all know at the beginning, anyone who were infected, they will be taken to a hotel. Some of those stayed for 15, for 20 days. So what we did, we established something called pharmacy care, and we deposited some amount to one of the staff's account, and we said, use this to help those staff and their families. So they were able to help them to buy groceries, to buy food, and send to their homes. I know all the apps were kind of like also surging during that time, but still some of the staff and their families did not have being familiar and how to use these apps and request their medications or groceries. The exposure list staff, they were working from home day and night. They bought laptops, they were attending calls from home. Their phones ran out of credits multiple times. We had daily meetings. I remember daily meetings non-stop until 2 a.m. just trying to fix. Every day there was a new issue. Every day there was a new issue. How to fix with the compounding, with the discharge, with the new staff who got infected, staff on the exposure. It was a really, really tough time for us. So if we look at staffing, yes, we went into telework, and you have to have the tools to do that. Inpatient capacity is dynamic because sometimes the hospital decides to empty beds in order to be ready to accommodate COVID-19 patients. So those staff will be taken to the outpatient pharmacy. Some of them will rotate shifts. So we had to put a recovery plan for that. Clinical pharmacy as well. This is a question about optimizing the care or serving a need of a patient right now. So they were on the ground helping in the outpatient pharmacy. I believe all the staff were like heroes everywhere. We had some also non-pharmacy staff. We had non-outpatient staff, similar to the clinical pharmacists and inpatient pharmacists. And believe me, they were like robots. Some of the clinical pharmacists, they were on the phone with our outpatient pharmacist, the clinical pharmacist on the ground, calling an outpatient pharmacist at home. They were directing them what to do. Go here, go in there. And this is an area also for us to think about in the future, how we can have that piece of training embedded into all the staff in case if this happened again, la qaddar Allah. Demand over supply, we were overwhelmed on the ground because of all the medications were verified, discussed with the physician, everything. However, there is no one there to take the medication, put it in the bag, and give it to DHL, put it in the drive-through pharmacy, or give it to the patient. We had very, very limited resources. So we needed help. We really needed help with this. So what we did, we looked at the non-pharmacy activities. What sort of activities that can be done by a non-pharmacy background? And we sought help from departments that they had their departments closed, such as dental. Dental, they were closed during the pandemic. They had no patients at all. So we got some of their dental assistants. She was taking care of the pharmacy admin extension, all the patient complaints, everything. She handled it in a very perfect manner. We had staff from the quality department who were ex-pharmacy staff. They helped us as well. We went to the nursing department. We asked them to help us with the medication preparation. We listed our remote and on-site activities as well. What activities can be done at home, on-site, and what activities can be done remotely. Through that, you will be able to see if these things can be shifted all the way from home, so that can be handled by the staff on the exposure list. Pharmacy Command Center, we had to establish a Pharmacy Command Center. Why? Because complaints were coming from everywhere. Our social media accounts were full of problems and issues, because at the end of the day, they are patients, right? They are patients waiting to take their medications. They don't know what happened inside the pharmacy. They don't know there was an outbreak. They had no idea. So for them, calling the pharmacy and no one is attended their calls, they come to the hospital, the outpatient pharmacies are closed. It was really a hard time. It was really a hard time handled by the staff in the pharmacy. But we needed to have that Pharmacy Command Center to tackle all of these issues. So we had almost 5 staff. One was assigned for Twitter issues, one for the phone calls, one on the site. And we had to build that Pharmacy Command Center. They're taking care of all the problems. Think about cloud computing. It's going to help you a lot with rather than sending documents from one end to another. Do it in a collaborative way, online cloud computing. Microsoft tools, alhamdulillah, King Faisal, they provided us with the tools. They were coming at the right time. We used it all nights, even in Ramadan and everything. So these are the take-home messages for today. Metrics, I want you to look at the daily metrics of your areas, because the new pharmacy is not the same as the old pharmacy. Don't think about the objectives or the KPIs. No, I'm talking about daily metrics that you should be looking at the end of each day. You need to map your new pharmacy. As I said, your new pharmacy after COVID-19 should not be the same as your old pharmacy before COVID-19. Focus on the long-term solutions. Focus on the issues. For example, the drive-through, yes, it's a good patient experience. It's a good service. However, look at the safety. There is no one there is going to counsel the patient properly. That's why we had to put in our pharmacy call center a dedicated extension for patients to call us and have their medications counseled. Issues with the courier services. Every day, they have a new mandate. All their parcels were stacked in Mecca. No other issues. So you need to think, put a new requirements, put a new mandate, revise your contract with DHL, Saudi Post, whoever. When you are putting your contract, think about all these issues. Go beyond the instructions. We had to daily check up on all the staff. If someone at home, if they were sharing a ride with another person, we had to check on all of our staff on a daily basis just to make sure that they are safe. And also by being safe, our operations, inshallah, will be safe. Go back to your seat. And this is a message to the directors, to the head of the departments. You need to go back to your seat. We left our seats. We were into the operation. We were trying to help our patients. However, you have to go back to this, to your seat to enhance the processes, look at the new initiatives, think about technological efforts and initiatives. And I repeated the word tech 4 times. trying to emphasize on this point. If you look at the pharmacy call center today, it's not the same as we started it. It's totally different now. We had to change all our service into a voice messaging service rather than direct calls. Why? Because by direct calls, you're going to consume the pharmacist and the patient's time. Having a voice message recorded, we can listen to it at any point of time. We can listen to it at night, at home, from anywhere. We can attend the call. Quality control, don't forget to always that you are the patient. Go and request a medication for yourself using the DHL. Go and pick up your medication using the drive-through pharmacy. These are the things that you should be doing in order to ensure the quality and the control of the service that you are delivering. These are some of the pictures that taken from our outpatient pharmacy. As you all see here, also in terms of the prayer mat, we had to cover it in a way that can be used by multiple staff. But before any time they pray, they need to wipe it out with the alcohol spray. And this is one of the innovative solutions, rather than we use plastic papers or papers and we throw it out. This is a good kind of like efficient way. We had to also sometimes serve our patients at night using our drive-through pharmacy. At the end, I wanted to say that we are all pharmacists, and I mean it. We saw how, despite the different backgrounds, the qualifications, at the end, we are all pharmacists trying to help our patients with their medications. And also I would like to thank, and really, wallahi ma mithlak fi dunya balad, we're so proud of being Saudis. We're so proud of the government initiatives and precautions that have been taken to help and to ensure the safety of the citizens of Saudi Arabia. We're so proud of our government. No matter what we do, we will not pay back whatever they have done to us. So this is something that we really need to reflect on a daily basis, especially at this hard time. And thank you so much again, everyone. يعطيكم العافية. And thank you, Sifa, for having me.
شكرا جزيلا دكتور عبد المحسن. You said it. I mean, we are so proud of being in this country and being Saudis. Alhamdulillah. And جزاهم الله خير حكومتنا رشيدة على كل ما قامت به. I would say it's a wow story, honestly. It's not really something that you would think of. However, you went through it. And I would say you are so lucky, Dr. Abdul Mohsen. I'm sure it had a very positive impact on you personally and all our colleagues and friends, brothers, sisters in your department. You had that chance to learn. You had that chance to reflect as well. جزاكم الله خير. All you have done for the patients, and I'm sure إن شاء الله تعالى ما راح شيء يروح بإذن الله تعالى كله بأجره. I have just a question and maybe some other questions later on when Dr. Shanawi as well present his presentation. A question for you. So you mentioned regarding the call center. This is something that you took over beyond or after the pandemic. So what else have you really took over and continued to provide in the new model after the pandemic?
Thank you, Dr. Hani, for this great question. I think when we started and we put our ideas, we were thinking about this way of serving our patients. However, now with patients taking their medications through drive-through or a mail order, they will have questions. There is a safety issue there, that there is no counseling anymore. So what we did, we rearranged our extensions again. So now if you call our extension, you will find number 2. It's about patient education. So if you want any of your medications to be to learn more about it, so you call this extension, you leave a voice message that my name is so-and-so, I have this medication, I want someone to counsel me. Then someone will go check your file, call you back, and then they're going to counsel you about this medication. And to be honest, in the middle of the whole kind of operations, one lady, she complained. She said that يعني يعطيكم العافية بتعطوني الأدوية وباخذ عن طريق السيارة بس ما في حد يكلمني الآن. That was, thank you very much. That where we had to change our pharmacy call center and add that piece to it. But the whole pharmacy call center now, it's done on a very old kind of fashioned way. Is there a room for improvement to have it in an application? Yes. Is there a room to have it in a virtual kind of like a mode? Yes. However, we still kind of just trying to get out of the whole thing, trying to get things organized. But definitely these kind of solutions are definitely going to be a huge impact and a huge service for our patients.
الله يعطيك العافية دكتور. I really don't want to take more of the time and موفقين إن شاء الله. شكرا جزيلا.
والعافية دكتور. شكرا.
شكرا. We move on to the third and last الحلقة الأخير الدكتور محمد الشناوي. The presentation is around the experience of the MOH during the pandemic as well, and it's around adapting a new era in delivering medication to patients. Our respected speaker today, as said, Dr. Shinawi, he's the General Director for General Administration of Pharmaceutical Care in Ministry of Health, Saudi Arabia. Dr. Shinawi graduated from King Saud University, and he gained his master's degree from Al Faisal University, Master in Business Administration from Al Faisal University in Riyadh. Dr. Shinawi has more than 20 years of experience at King Faisal Specialist Hospital, and he has a vast experience in operational, general management, staff engagement, and management, human resources, organizational planning and design, monitoring, and statistical analysis. He has been very well engaged since joining the Ministry of Health in having an impact and elevation and enhancement in the pharmaceutical care services provided by the MOH. Without further ado, I leave it for you, Dr. Shinawi. تفضل.
Thank you, Dr. Hani Al-Hamdan. Actually, it is my pleasure to be with you, and it's my honor that Dr. Hani Al-Hamdan by himself introduced me in this conference. I believe this is one of the biggest conferences in the whole region, in the Gulf region. Thank you, Saudi Pharmaceutical Society. Thank you, SIFA 2021 Scientific Committee for this kind invitation. And without further ado and delay, I will go immediately to my topic today, adapting to a new era in delivering medications to patients. As Dr. Hani Al-Hamdan, he introduced me. My name is Mohammed Al-Shinawi. So our objectives today, it will go through identifying the needs. Why do we need the home delivery? Do we have a need to deliver the medications to patients' home? Or there is no need? It is just only an option that we need to deliver it. Challenges. What are the challenges that we are facing in COVID-19 pandemic era and after COVID-19? I believe that, and I said it many times, that I don't believe that the world after COVID-19 will be similar to the world before COVID-19. Knowing the requirement, what are the requirements? Then I will go through the planning, monitoring, and launching, and then I will end by evaluating and improving the service provided to our patients. Is it really needed? So we asked this question to our pharmacists, to our colleagues. Do we really need the home delivery or the mail order service to be in reality on ground in our hospitals in the Ministry of Health? Of course, we didn't had 100% of our colleagues say yes. However, we had two teams. The team we are with, it is more suitable for patients, not just only for patients. As we all know that everything now is preferred as a home delivery. Home delivery medications, home delivery, food, home delivery, grocery, anything that you can ever imagine, perfumes, anything that you can imagine, it is nowadays is preferred to be as a home delivery. It is time saving for our pharmacists. So it is saving our pharmacists time. So our pharmacist, instead of, for example, if they can produce or dispense 100 prescriptions a day, with the home delivery or with the mail order services, they can produce and they can deliver 120 or 150 or even 200 prescriptions per day. It is eliminating the patient accumulation in front of the pharmacy, especially if we will know that the patient or patients may have some kind of virus transmission during especially the pandemic season or pandemic time, that they can transmit the virus from one infected person to another. The people that they are with, they are saying that it's cost saving. It is saving the cost of the patient, of the pharmacist, of the hospital, of the ministry. And I put two exclamation marks here that I will talk in details in clarifying this by numbers. It is time saving for everybody, not just only for pharmacists, as we mentioned in the second point. It is time saving for everybody, for patient, for pharmacists, for the hospital, for the physicians, for everybody. And it is very useful in special situations, example like the pandemic era. So if we will talk about the people that they are against, those are mainly our challenges. Those are mainly our people that we want to concentrate on in order to either to negotiate with them or to convince them that we covered all of your points. As my colleague, Dr. Abdul Mohsen, he mentioned that they faced the problem of no patient's counseling. Yes, there is no patient counseling in the medication delivery or the mail order delivery. So how we overcome this, we will come to it in the next slide, inshallah. It's not saving any time. As the pharmacists, some pharmacists, they said that we are preparing the medication and we are dispensing it, whether if the patient is in front of us in the window or he is sitting at home. So we are preparing it no matter how, no matter when. The third and important point that they mentioned, it is decreasing the role of pharmacists and converting pharmacists to maybe dispensers instead of pharmacists. So how we overcome this and how we maintained and how we enlarged the role of pharmacists in that one. The same point that the people or the group with the with, they said that it's cost saving. The people with the against, they said, no, it's not a cost saving. Actually, it's costly. How come that you are saying that you are saving our cost and you are paying the company money to deliver this, to deliver the medications to our patients? And again, the same point, it's the time saving. The people in the against, they are saying that it is a time consuming. Having the patient in front of me, maybe it will give me some kind of acceleration process in order to dispense it in a timely manner. But having a medication prepared in the backyard or after hours and not having the patient in front of us, maybe it will delay us and it will make us work in a smooth or in the safe mode work or power. And you are saying that the mail order was just only in the pandemic era, in the pandemic time, and the pandemic situation, inshallah, will be over very soon. Inshallah, hopefully. So our challenges with the people that they are against. So the patient counseling process. So we developed now that our pharmacist can go inside the application ANAT, and I believe ANAT is very well known to everybody. ANAT is an application that you will log into ANAT by using your Saudi Commission for Health Specialty number. It's connected directly to your registration, and if you are registered, you will have an access. If you do not have a registry, or you are not registered in the kingdom, or your registration is already expired, not renewed, you will not be able to have an access to ANAT. So our pharmacists now can go inside the application, and they will have all the patients that they received their medications and for the first time, and the criteria for patient counseling process is depending on them. They will find them listed here. Then he will go first one by one, and he will open the link, and he will start to communicate directly to the second phase with the patient. He can communicate in this field by chatting, typing messages to the patients. And here it will be a voice and video conference. The patient will be able to see the pharmacist, and vice versa. The pharmacist will be able to see the patient as well. And after completing all of this conversation, of course, during this time, the pharmacist will have an access to the medication profile and medication history for the patient, as the ANAT will be connected to a majority of our HIS systems and the MOH. And of course, that we will not have the lab result. And the lab result, maybe the pharmacist will be able to have or to open right now the HIS in order to get all of the patient information and the patient profile during this time. After the pharmacist will complete the complete session with the counseling of the patient, of course, he can see the medication delivered, and he can see the exact patient and the labeling, and he can counsel the patient with the medication boxes in front of him, or in the video or in the camera. After that, the patient himself will have an ability to evaluate the whole process by putting stars and putting his comment in order to improve and monitor our service that we provided to our patient. So by having the comments from our patients, we will be able to enhance the system and enhance the counseling application more and more. And I don't believe with having this counseling process technique and application that the pharmacist role is minimized. I believe that we enhanced the pharmacist role by having this counseling process, by changing even the counseling process from a face-to-face and manual process to a highly tech application that the patient will have an appointment and he will be counseled exactly like the counseling clinics inside the hospitals. So is it really saving, is it really saving the patient and pharmacist time? If we will go here and make a graph for the daily dispensing pattern or curve in any pharmacy, if we will forget about the numbers here, the curve will be almost similar for all hospitals. All hospitals will have a morning clinics and afternoon clinics. In those clinic times, we will have two peaks. The two peaks will be almost around 11 or noon time. This is to cover the morning clinics. Then the peak will go slightly dropping down. Then at almost 2 or before 2, the curve again will go and will go to be increased again to reach the peak time again around 3 or 2:30 p.m. for dispensing of the medications for the patients that they attended the afternoon clinic. So this curve, it's copy and paste from majority of the hospitals. Our hospitals, they have the same process, and I believe our colleagues in other healthcare sectors, they have the same process. So this curve actually, and those two peaks, those are the problems that we will face. Those peaks that majority of our patients will be accumulating in those two peaks. So in order to get rid of the accumulation of the patients in those two peaks, we need to flatten the curve and expand the serving hours. So how can we flatten the curve? And instead of having some kind of our patients and the patients that our criteria fulfills them, so we will make this curve more flat, and we will expand the serving hour for 24 hours. So the theory that having an ambulatory pharmacy is working just only in the day or in the daytime, with the home delivery, it can be expanded, and the workload will not just be only focused in 2 hours or 3 hours, just only in a day. So our target patient population, first of all, the chronic patients, the patients that they are receiving their medication chronically, like for example, the antihypertensive patients, or the patients that they are receiving or they have the high cholesterol levels, and they are taking the anti-hyperlipidemic medications. The second patient target, those are the home care patients. And those are the patients that we are sending the whole health team or the medical team to them inside homes to evaluate their patients and to put their treatment plan. And it's not logic after sending the physicians and nursing and everybody to those patients at home, then to ask those patients to come to the hospital to receive their medications. The refill patients, those are the patients that they know their medications, and they almost count for 1/3 of the total patients visiting any of our ambulatory pharmacies in the MOH. They are coming for a refill of their prescriptions.
3 minutes, Doctor.
Sure, Doctor. Virtual clinic patients, those are the patients that we started the service for the virtual clinics. So the physician will see the patient virtually. And of course, again, it's not logic to ask the patient to come to the hospital after the physician seeing him, to come to the hospital to receive his medications. Patients living outside the city, and of course, geriatric patients and patients with special needs. Number of patients during COVID. It's my honor that my colleagues in all over the hospitals, pharmacists, pharmacy technicians, and volunteers, they delivered more than 367,000 parcels to all over of our patients inside the kingdom, with more than 72,000 patients were counseled virtually. So if we will come here, after the COVID-19 era from March to, or timing with the lockdown from March to August, we started to have a plan that we need to find a best delivery carrier and the medication requirement with the temperature requirement of the medications, with the secure delivery requirements and KPIs and monitoring and patient satisfaction. Our selection went to the Saudi Post, as they are 100% a national company and they fulfilled all of our requirements. So the service will start from the MOH. We will make a guidance to our hospital what to do, what is the policy of the home delivery. Then once the hospital is launched, they will communicate directly with the Saudi Post, and the Saudi Post will come to deliver for the outside, parcels outside the city. They will deliver within 72 hours and 24 hours inside the city. Patient received the package from the Saudi Post. I will not go for the details because of the time. And again, this is starting the whole process for delivering the medication starting from the hospital, from the patient requesting his medication until the medication reaches the patient. And of course, here, this is the ordering portal where we can request the airway bills and delivery and put the patient information with the national address for our patients. And this is where we can track our shipments. And this is the most important thing. How can we be ensured that our patient is the right patient, or it was delivered exactly to our right patient? Once the airway bill is generated from our hospital, the patient will receive an immediately tracking number that the shipment will not be considered as delivered to that patient unless the patient gives this number to the driver and to match the number in the shipment, then the shipment will be considered as delivered. Some statistics that I want to share. In the last quarter in 2020, we shipped almost more than 106,000 shipments to our patients all over the kingdom, with an 88% of it non-fridge parcels and 12% fridge parcels, 60% of them inside the city and 40% of them outside the city. Again, the cost saving just only for the last quarter, keeping in mind that the royal decree that any patient will receive his medication or receive required to travel from his city to outside, the government will pay him almost 500 riyal for this travel per day. So by counting this and by evaluating this, keeping in mind, and we have calculated as well the cost of this 100,000 shipments, the cost saving for the Ministry of Health during the last quarter only in 2020, it is more than 25 million Saudi riyal. So by this, I end my presentation. I hope that I did not take longer time. And thank you, Mr. Chairman, for giving this to me this opportunity.
Thank you so much, Dr. Shenawi. Honestly, I feel very delighted to see this milestone in the patient care, patient experience in the Ministry of Health, which is covering most of the population in Saudi Arabia. We are going definitely to learn from you, and we'd like to thank you for all the efforts in making that change. I would like to ask a question, Doctor. I noticed that there are about only 20% of the patients who got their medications delivered got their counseling virtually. So was there any challenges in the process, or it's an option turned down by the patient?
Great question, Doctor. The patients that they are receiving the new, those are the patients receiving the new medications dispensed for them. Those that they receive the counseling process through the counseling clinic or through the virtual counseling clinic. Majority of the patients that they received were refill, and majority of the during delivery personnel during the pandemic were either pharmacists or pharmacy technicians or pharmacy volunteers that they are students. So counseling were done while giving the medication to the patient, because it was done by our pharmacists and pharmacy technicians and the volunteer during that time. So yeah, it was opened. Some criteria was taken in consideration if the patient is receiving a new medication and this medication is really required to be counseled for the patient. And it was opened as well for patients to call us or to request for a counseling session to be done by themselves as well.
Great. So another question is, as far as you are going to continue with this service post-pandemic, what are the solutions for the controlled medications?
Yes, great answer. Great question, Doctor. We are working right now with Saudi FDA. Yes, we had it active during the pandemic time and the lockdown, that we had an exceptional approval from the Saudi FDA and from the committee that it shared this. And now the committee, it's combined committee from the Ministry of Health and Saudi FDA. We are discussing something like this to be happen after the pandemic era, and to change the whole thinking about making the patient traveling just only to take a tramadol or Tylenol 3 from Riyadh or from the reference or the referral hospitals, especially the patients with the oncology and those. So I believe that in the next couple of months, the new regulation, permanent regulation, will come, and the selection of the companies for delivery and the authority will be given from the Ministry of Interior to those companies in order to deliver the narcotic and controlled medications.
Allah yabashik bil khair. Mumtaz. That's really great news. Another question for both of you and Dr. Abdul Mohsen, if he's still around. I wanted to ask you about the call center. What's your thoughts about the call center? Whether should it continue to be handled by pharmacy staff, or to be handled by like patient services staff, patient relation staff, or even subcontracting this service? When I talk about call center, I mean receiving calls, not giving any information or counseling or education to the patients.
طبعا هو دكتور يعني for all the companies يعني usually the call center is handled by the frontliners يعني help desk, and they can direct your inquiries to different areas. However, if you look at the call centers for the banking sector, it's more sophisticated. You call in, then you have an option for credit cards, you have an option for if you lost your card. So it's actually based on how the whole organization is willing to utilize it. If they're going to utilize it in a way that is going to help the patient to map their journey until they reach where they want, that's going to be manned and resourced in a different way rather than in just a call center. An advanced call center, it's not only the whole concept of the call center used to be there, especially for those calling the banks, but majority of us now are doing all of our transactions through the bank's applications. We are not calling them anymore. Can this take away the call center? Definitely, but we should set a plan for this. We should put a way to develop an application, or if you already have an application, to add these features built in. But until then, we have to have that kind of middle solution that is going to help you to see the needs of the patients and fulfill them, and it's going to map your design of the whole app when you are going to do it, because now it's considered to be also part of the learning journey. We're identifying the needs, and as described by Dr. Mohammed Shenawi, that they developed the platform, so can the app of King Faisal, for example, be integrated in a way that pharmacists can deliver their services using their platform? That's I think and SIFA is always been a pioneer in this, but I think we really need to have that kind of high level meetings with the directors of pharmacies here in the kingdom to really streamline the ideas and the thoughts and put in front of us the Vision 2030 and see how we as pharmacy can contribute to that as well.
الله يعطيك العافية دكتور. دكتور شناوي.
طبعا يا دكتور انا يمكن فهمت من سؤالك اللي هو موضوع الكول سنتر يمكن يكون عليه مثلا او اوتوماتيك انسرز او يكون في اللي هو النون هيلث كير وركرز، بس اعتقد في الفارماسي لا، احنا we need to have a dedicated personnel يكون ان هو موجود في الكول سنتر. maybe يعني in the future we can have for example somebody that he will or the message that it will be recorded in the system, in the call center. Another way of communicating that sorry for that, that any patient anywhere in the hospital, anywhere in the kingdom, they can call our call center. This is the 937, and they will have a professional staff that they will answer them. Some of the professional staff are pharmacists, and if there is a call that it will, they are asking about medications, it will be automatically sent to the pharmacists, covering 24/7 in the call center 937.
Actually, why I asked that question, because throughout the pandemic in our institution, National Guard, we learned that the staff are really very valuable. So we wanted to maintain them and retain them to work for patient care focused area and service. So we worked collaboratively with our patient relation department. The National Guard established a platform called WeCare to be a communication tool between the call center, the unified call center, which is run by patient relations, and the pharmacy, and other departments as well, like patient services for admissions and appointments. But I mean, when it comes to pharmacy, they are receiving the calls. That's a part of other channels, but they are receiving the calls and communicating through that communication/tracking system to the pharmacy, for the pharmacy to action it. So I said, I mean, maybe this is something maybe we can think of. I mean, our testing for that module, inshallah, so far it's really successful, and inshallah it's worth like presenting or to all upon completing a good time. Another suggestion related to whatever Dr. Abdel Mohsen said, I mean, I would leave it for SIFA to take it on honestly. I would really suggest to have like a branch from SIFA for pharmacy directors. To be a hub for pharmacy directors. This is something like, you know, adapted by ASHB. There is a special forum for them. It is very helpful. It's going to be so fluctuating with regard to the communication among all pharmacy directors and exchanging the solutions for challenges and things like that. And SIFA being our national project, ما بقول إنه SIFA is a SIFA project, it's a national project. Allah يجزاهم خير. I'm sure inshallah they are going to adapt that. At the end, I was really delighted, very happy to be among all you doctors. Jazakum Allah khair for all the presentations and all the efforts you put before and now on. And thank you very much for the scientific committee, for SIFA, for the invitation. And wish you all the success on the remaining sessions, inshallah. نراكم على خير بإذن الله.
السلام عليكم.
السلام عليكم.
شكرا دكتور محمد.